here to make it at least a bit easier, or make you understand some concepts that I felt it was lacking and I did not understand it. We were not asked about it بالفاينل, بس it was very important for your own sake of understanding. صح؟ Okay. Just let's start asking you guys, does the brachial plexus gives motor branches or sensory ones?
Both actually, both.
Both, right? Why?
There is musculocutaneous, there is motor and motor.
Exactly, musculocutaneous is the best example because it starts as muscular and then it continues as cutaneous branches to innervate the skin. Can we close the door? So as long as it gives both of them, how this is gonna work? Let's go back to the spinal cord because last year technically, because I'm here, I did not understand this concept, so I wanted to slightly touch upon it for your own understanding. We have the spinal cord. We know the brachial plexus extends from C5 to C6, 7, 8 to 31. Yeah, exactly. Here we have the fibers that are going to connect together. We have a dorsal root and we have a ventral root. Here you have a better view. We have the dorsal root and it has a ganglion, right? But the ventral side does not have one. They're going to connect together and this part is called the spinal nerve, right? This is going to come out of the intervertebral foramen. Did you get exposed to it?
Yes.
Yes. So basically we're going to see this as the first part, the intervertebral foramen, the spinal cord going out of it. And then we're going to have dorsal rami and ventral rami. What I wanted you to understand is the dorsal root is responsible for motor or voluntary?
Involuntary.
No, motor or sensory?
Sensitive.
Sensory. And the ventral? Motor. In the spinal cord, basically what happens that the fibers are going to mix together, and when the ventral rami and the dorsal rami, both of them are going to have both voluntary and sensory and motor together. Okay, I'm gonna pause here, and yeah, this is how I used to remember that the ventral root always responsible for motor, a motor cycle with a Venn cell. Okay, I paused there, and I'm gonna go directly to the brachial plexus, and then we're gonna have a small relation between them. We know that the brachial plexus starts from where? As roots, then trunks, divisions,
cords,
and cords. Yeah, that's it. Okay? And this is a mnemonic for you. Remember to drink cold beverages, to remember their order. Okay. So we mentioned basically that here the roots and every other aspect should be innervating motor and sensory at the same time, right? So starting from our root, it should have the motor and the sensory. Like if we went back, we mentioned that the roots here are giving only motor, not sensory, right?
Yeah.
So what's happening?
I'll give you what's happening.
Yani, why our roots in the brachial plexus? Mo, you answered me, you told me both motor and sensory.
Yeah.
But here, when we're going back to the spinal cord, which is giving the brachial plexus, right? You're telling me now that one root is giving motor and one root is giving sensory.
But they join at the spinal nerve trunk.
Okay, so basically the root of the, where's the root of the brachial plexus?
The trunks?
No.
No, no.
The root of the brachial plexus is,
The ramus.
yeah, it's only the rami.
So it does not have dorsal and ventral root.
Did you get it? No. So basically the roots of the spinal cords is totally something different than the roots of the brachial plexus, okay? So to be ordered, basically we start with the spinal cord. We had both roots, the one that's utterly motor, which is the ventral one, the one that's utterly sensory, which is the dorsal one. They connected together as a spinal nerve,
And
okay?
they make it trunk.
And then they made, no, they did not, yeah, they made the trunk, but this is for all for the spinal cord. Then we had, again, division, which is the dorsal rami and the ventral rami. The dorsal rami has a motor and sensory, and the ventral rami had motor and voluntary. The ventral rami only is the root of the brachial plexus. Did you get it? Okay. So this was a very important point to touch upon.
So
You will not encounter it. One minute. You will not encounter it in the final, but this was very important for you to understand. Okay, so you keep it in mind. Yes.
Question.
Muhammad.
so does it من C5 to T1 does it have the dorsal and ventral root or
No. Basically, the roots here, whenever I say a root of a brachial plexus, in the language of a spinal cord, or if I'm referring to spinal cord, what am I meaning?
The ramus.
Ventral rami only.
Oh.
okay?
Okay? Did you get this point?
Yes.
Everyone?
Yes.
Okay.
Yes.
Okay, here the divisions and everything is a bit easier. As we said, roots, trunks, divisions, and cords.
Then branches.
Here, yeah, everything is systematic. We have here the C5, C6 coming together, C7 is alone, and C8 and T1 is together formed in a lower trunk. And now each trunk, as we see, it has an anterior and posterior division. Even this one is its anterior division, and this one is its posterior. Okay. Now we're saying here that the anterior division itself is going into a lateral root. The posterior of both of the three trunks is going into a posterior cord, and the anterior of C8 and T1 is going into the medial cord. These are very simple, like I don't want to go in deep with them because they are common sense. Okay, whenever I'm saying posterior, anterior, only regarding the cords, I'm referring to what? Posterior to what? Medial to what?
Okay. The axillary.
Artery. Which artery? The axillary artery, right? So if I'm saying lateral cord, it's lateral to the axillary artery. Medial to axillary artery. This is gonna help you in OSPI when you're going to have the artery, because the artery يعني أكتر شيء مبين. We don't have non-Arab speakers, huh? Okay. أكتر شيء مبين, you're gonna relate to it. This is a schematic one. Okay. Now we're gonna understand what are the divisions that we're going to have for the roots, for the trunks, etc. For the roots, it's only the one above. We're gonna take three. First of all, the most important one, you're gonna have so many questions. C, 3, 4, 5. Oh, okay. You are not gonna have questions about this. But you should know it for next year. 3, 4, 5 keeps phrenic alive, which is
For the diaphragm.
phrenic for the diaphragm. If we cut it,
Lethal death.
death, because they can't breathe anymore. Okay, this is very important. The long thoracic. What are the root values? 5, 6, and 7. There are some of them that you need to know the root values, and some of them you're not required. But the most important one, long thoracic is important, and we're gonna go one by one to mention it. Injury to this will lead to
Winging.
winging scapula, exactly. Again, here we have dorsal scapular that's going to innervate the rhomboids and levator scapula. Levator scapula was not mentioned in your lecture. It's going to be mentioned
It
with
was
the
mentioned.
anatomy,
It was
like
mentioned.
not the brachial plexus.
Yeah, but you took
the
it.
ones, yeah, اللي بعده. Okay. After that, we have the trunks. We don't have divisions from the middle and the lower. We only have from the upper. The upper one is also called herbs. Okay, so what's the root value? C5, C6. We have also two divisions. The suprascapular, I used to memorize it as supraspinous, and the scapular is the other, like the two muscles of the scapula, which is the supraspinous and the infraspinous. It innervates them. And the subscapulus, it has the root value of C5, C6. This is all, like I'm skimming towards them because like it's not my main focus. This is only for you to memorize, okay? Okay. So here there's a mnemonic to memorize the roots and the trunks divisions, which is Phillips doesn't sell sour lemons. It's up to you to use any mnemonic, anything that makes you relate which branch this branches to a root, a division, trunk, etc. I want to emphasize on this because we're going to have some questions about it. Do you remember this? It was in your first, I think, the first one, the second week. Here, the abduction, يعني, this picture alone can have 3 to 4 questions in the exam. Okay, each one in a different form. And you have to know the angles. For instance, you get a picture in the OSPI pointing at the deltoid. They're gonna tell you, mention the movement of this muscle. You're not gonna be like abduction. You're gonna say abduction from 20 to 90 degrees, or from 15 to 90. They usually follow 20, not 15. That's okay. So, for instance, they tell you he got an injury in the, what's the nerve innervating the supraspinatus? Suprascapular, right? So he got an injury in the suprascapular. What do you expect?
Unable to
He cannot initiate abduction. This is very important. In the question, he might be asking you, he cannot initiate abduction, and he did a maneuver. And now we're gonna talk about it when we have a question about this point specifically. And he might tell you he's abducting a little bit, but he cannot raise his arm above his head, okay? So it differs. 0 to 20 is the supraspinous, and you have to know the nerve of it. The deltoid is innervated by which nerve? Axillary, yeah. And the rest, the serratus anterior, long thoracic, and the trapezius. I don't remember the trapezius. The serratus anterior is the most important one. Okay, again here, the lateral cord, I always used to remember it as LLM. Okay, we have the lateral root of median nerve. We have the lateral pectoral, and we have the musculocutaneous. Musculocutaneous is basically the continuation of it. You have to know the root values of these. For instance, he told you, a question came and asked you, he got an injury in the lateral pectoral nerve. Which muscle is going to be impacted more? Major. Because major is mainly supplied by the lateral pectoral and a little bit supplied by the medial pectoral. Okay, hello, we're gonna discuss it. And the pectoralis minor is mainly supplied by this one, the medial pectoral, and the pectoralis major is a little bit supplied by this one. So basically, an injury to the lateral pectoral is going to impact the major more than the minor. And the same thing goes to the medial pectoral. The medial is basically going to impact the minor more than the major. And there is an important point to emphasize on. We have certain muscles that are supplied by different root values or different nerves even, right? Such as, tell me, give me an example. Brachialis. It's supplied by 2 nerves. Radialis and
We took this lecture today, so
Okay, okay. Now we're gonna talk about it. As what I was saying, if we have a muscle that's innervated by two nerves, and one of them was injured, what are we expecting? A full paralysis or a weakness?
Weakness.
Weakness. But if we have a muscle that's supplied only by one nerve,
Paralysis.
paralysis. So even in the OSP, if they asked you, this nerve was cut, you expect a paralysis in which muscle? You would think of a muscle that's only innervated by, like utterly innervated by only this nerve. Even if this nerve supplies another muscle, the other muscle would be having another one that make it a bit handle this injury, but not be utterly paralyzed, okay? So you have to keep this point in mind. Okay, so here we discussed them. We discussed the branches. Going to the medial, it's always M for you. We have two cutaneous ones, which are medial cutaneous branch of arm, medial cutaneous branch of forearm. Which one is taller and which one is shorter?
Taller forearm
Mhm.
and shorter arm.
Yes. And which one is thicker and which one is thinner?
I think the arm is thicker
Mhm.
and the forearm is thinner.
Yes. And we have the medial root of median nerve, right? And as we can see, the median at the end, because he took from here and here, he ended up having all the root values, okay? And the continuation of the what was it? The medial cord is this the medial cord? Yeah, the ulnar, right? Dot. Yeah, because this one, the middle is the posterior. Okay, the ulnar. Okay, can you give me a look at the ulnar one? The ulnar is from where is the continuation, as we said, of the medial cord. The medial cord took its roots values from where?
C7, 8 and Q1.
Okay, طيب, why is it C7, but we only have C8 and T1
Because of
having
this red one.
continuation?
Red one connected.
Yeah, if we see this picture is giving a better view, there is actually a communication between them. So some fibers from the C7 would escape to the ulnar, okay? That's why it's taking, although it's the continuation of the medial cord, and the medial cord we've known that it's only C8 and T1, but it has some fibers from C7, okay? So you keep that in mind also. I just want to make sure. Okay. If we had an injury in the medial cutaneous and of the arm or forearm, what are we expecting to have?
Lots of
Sensation.
Sensation. Hmm? No,
No, no.
because it does not innervate any muscle, right? It's only a sensation. Okay, going to the posterior one. Posterior one it's mnemonic with ultra. Okay, we have the upper scapular, lower scapular, the thoracodorsal, radial and axillary. They are the continuation, and then they divide. Okay, but notice that the radial nerve has all the root values, but the axillary only takes the C5 and C6. Okay, the axillary, as we mentioned, it supplies the deltoid. So we have to keep it in mind as one of the nerves if he asked about abduction, okay? Then we're gonna focus, if he mentioned certain angles, he mentioned the initiation of abduction. Am I concerned with this nerve?
Yes.
No.
No, because initiation.
Initiation.
Initiation, I'm concerned with which nerve?
The subscapular. No.
Suprascapular.
Suprascapular.
Suprascapular. Which muscle?
Supraspinatus.
Supraspinatus. Okay. Here, the subscapularis, for instance, notice that it has an innervation from the upper scapular and the lower scapular. So a cut in the upper scapular would not utterly paralyze this muscle because it has another one. But for instance, for the teres major, a cut in the lower, for instance, they get you injury in the lower subscapular. Which muscle is going to be paralyzed? You're going to focus on the teres major. because you pretty know that the subscapular still have another nerve supply, and the thoracodorsal for the latissimus dorsal. I'm not sure that we have a question for that.
Doctor, will you share the slides?
Yes, I'm gonna give you the slides, and they have notes. That's why I'm going through them to make sure that I'm covering all the points. Okay. An injury in the axillary.
Atrophy of the deltoid.
Atrophy of the
Loss of contour.
Loss of contour. What's its name? Flat shoulder. Yeah. They might get you the picture, or they might ask you, they point about the deltoid and ask you what's the clinical presentation of this person. You can mention loss of contour, you can mention flat shoulder, what's the movement lost in this injury?
Abduction.
Abduction. This is a urot abduction, you're gonna take
abduction from 20 to 90 degrees.
Yeah. They're so strict. You have to mention the angles, especially in the abduction. That's why it's the only movement you focus on, because 100% you're not gonna escape with the exam without 2 to 3 questions about this. Yes.
Sometimes they say from 15 to 90, and sometimes they hit from 20 to 90.
Yeah, roughly from 20. Like, to be honest, in all the other resources, I usually used to see 20, and I remember Dr. Suni mentioned the 20. But like roughly 15, or if you mentioned 15 or you mentioned 20, it's not a big matter, okay? Because you can't be mentioning 30, 40, okay? But I used to follow 0 to 20 and the 20 to 90, and I was good to go. Okay. Yes, you answered this one. If I ask the patient to abduct, what I'm gonna be expecting?
Just a bit.
0 to 20
Yeah, 0 to 20. He might be raising his arm after that, and this is a maneuver. We're gonna encounter a question about those 2 maneuvers. The patient might be present. Here I mentioned that the axillary nerve passing through the quadrangular space. Do you remember those spaces from the axilla bar point?
Slightly.
Yeah, we're gonna see the slide after that, but this is very important when they tell you about relations, even the anatomy slides, when they tell you, for instance, the musculocutaneous pierces here, enters between this muscle and this muscle. They're not gonna ask you in the theory, but this is important for you to orient yourself in the OSPI. So like, we're not expecting you to memorize it. حتى نحن, it was hard for us, but whoever was memorizing it, it was easier for him in the OSPI. So try to familiarize, like whenever you're reading the slides, try to go over complete anatomy and actually see the root of the nerve, how is it going, okay? Here we go for the clinical presentations. We have first one, the Erb's palsy. We have the Erb's trunk, which was, the root value of it was C5 and C6. Here, you have to know the muscles, and you have to know, they're not gonna ask you about the muscles. What they can ask you about, like pronators, supinators, like this, like what part was paralyzed. Yeah, for instance, they get you paralysis, which was Erb's palsy. They're gonna ask you in the multiple choices. For instance, pronators or supinators was paralyzed. Yeah, you did not. Did you reach forearm?
Forearm, no, listen.
There was a slide after that. I removed it. It had the muscles. Okay, when you reach to it, we have the Klemsky paralysis, which is, again, they might ask you about the root value. They might describe the patient. For instance, he's having extension in the first 3 digits, while having flexion in the last 2 digits. Okay, مثلا a patient came to your clinic and you saw his hand in this way, extension of these and flexion of these. You should be knowing that it's they're not gonna ask you about the name itself. They might be asking you about the root values more, to be honest, okay? But like try to understand how they actually describe the deformity, because you might not see it in the theory, okay? This is very important. This is golden. For sure you're gonna gain, if not all of them, at least 2, okay? So we used to memorize it with Dr. Coleman mnemonic, and it was a lifesaver, like it was more than enough. And here we had the description of it. See here, we're having extension of the first 3 digits. So basically in the theory, they're gonna be like, a patient came to your clinic with the extension of the 3 digits. What do you think the muscle paralyzed? You're gonna be like, Dr. Coma, A, ape's hand, M, median nerve, okay? They might ask you about the root value, they might, basically the root value. Or in the OSP, they might give you this picture and ask you which nerve is injured, okay? So these are easy marks, don't lose them. Whenever you see a clinical presentation, be sure that in the theory you're gonna encounter it, and in the OSP you're gonna encounter it, okay? Know how to actually differentiate it if it was written, or if you got the picture itself, okay? Yes.
How would they, when they're explaining either claw hand or hand mobility, how would you
كيف
shape?
تعلي صوتك؟
لو مثلا عندك apes hand and the claw hand, how would they describe between these? They're very close.
Okay, basically here, this part is the injured part. So these are basically fixed, he can't move them. These are free. And one thing that was very important in the ape's hand, I don't think it's mentioned here, they're gonna tell you that the thumb is basically adducted to the first finger. So basically it's like this. But here the injury is here, so you're gonna have a flexion of those 2 fingers, and these are free. So the issue is here, okay? And I'm not sure if you took it in the examination or not. Did you take the tendons commissures? You did not? I'm not sure if you're gonna take them, so I think you are. Commissures are basically different than the paralysis. Paralysis, a paralyzed person coming to you, you can basically move them. You can come and actually move them. When you have commissures, basically the tendons are shortened. They're going to be fixed, like مثل خشبة, literally. You can't, like you're trying to push it, but you can't. On the other hand, the paralyzed person, you can actually open it, but it's gonna come back to its normal position, okay? So this is a difference. But they're gonna tell you, like, he came in the theory, they're not gonna ask you about the commissures. They're only gonna ask you about this one. That's gonna be the claw hand. And as I told you, here the injury is basically in the other 2 digits. Whether here, it's in the first 3. And you're gonna understand them when you get to the hands week, okay? And the wrist drop, which one? Radial. They're gonna be like, the hand is flexed, okay? Here, the cervical rib, what's important to know, you might encounter it in the OSP as which trunk would it impact the most? Lower trunk. Why? Because the extra rib is going to be where? At C7 vertebrae, right?
C7.
Yeah. So basically it's gonna be pushing where? The C8, T1, which is the lower trunk. What is the paralysis you're expecting at? What's the name of it? Klumsky, right? Okay. We come to the questions. Is there anything else you want to further explain?